The moment you suspect septic shock in a patient, what's the first thing you want to do? You want to give fluids. Yes, you're going to do a septic workup on patients. Pretty much everybody's going to get what basics workup? UA, chest x-ray, blood cultures. Everybody gets that most of the time. If you don't find any source from there, or if there's any other concern for any other infection like diarrhea or abdominal pain, you can scan the patient's abdomen to look for a source. Or if you're suspecting meningitis, look for a source. Important thing is to do a septic workup. But from a management standpoint, your number one thing you want to do in a patient with shock is give fluids. How much fluids?
30 cc's per
30 ml per kg. That's what you're going to give. So if somebody is 70 kilograms, 30 ml per kg will come to about 2.1 liter. You want to give that as a bolus first, and after that, you'll still run high volumes of fluid. Now again, a very bad misunderstanding is, can a patient with CHF get septic shock? Yes, he can. He could have a bad heart with an EF of 25%. He could clinically look fluid overloaded, but now he could have developed a UTI. And he can come with septic shock. So just because he's coming with septic shock, are you just going to blindly give him fluid? No, you're not. No matter what the patient, just because the patient is in septic shock right now, and he's got a CHF from before, doesn't mean you jump to fluid straight off the bat. Yes, most of the patients will be dry because it's a vasodilatory shock, they're volume depleted, they need fluids. But if the patient looks volume overloaded, don't give fluids. Assess volume status. It's bad to blindly give fluids to everybody. So when they did the Surviving Sepsis campaign, initially, they basically said give 30 ml per kg of everybody. But then later on, the revisions, they said no, assess volume status appropriately and give fluids as needed. But this is how you assess the volume status like we spoke about. What type of fluid would you give? Isotonic. What are the isotonic fluids we know of? So you can give LR, which is the most isotonic because your sodium is about 134. That's where you're going to be. Okay. What about normal saline, which is another isotonic fluid, which I'm going to put at second place. Why? Because how much sodium do you have? 154. So your normal sodium is between 135 and 145. So 154 is technically higher. So it's not really isotonic. It's a little bit more hypertonic than not. But LR and NS, the idea of giving an isotonic fluid is so that it stays within your blood vessel. Because whatever fluid you're giving, imagine if it's a vasodilatory shock, it has a tendency to seep out. So the moment you give them a hypotonic fluid, like say a D5 half NS or a half NS, hypotonic, the fluid tends to seep out of the vessel and your blood pressure will still be low. That's why you want to go with isotonic fluid first. Okay? So typically you're going to play around with LR and NS. What if your patient is hypernatremic when they come in? It's 160. Are you going to give them LR or NS?
You can.
You can? Are you not going to increase your sodium?
No, there's a difference. It's still.
Because the sodium you're giving on your normal saline is 154, so it's less than 160. So technically you're hypertonic relative to what the patient has. Let me put it this way. When somebody's got hypernatremia, your traditional answer is always going to be D5W. Okay, you calculate free water deficit, see how much fluid they are deficit, you give them in the form of D5W, never NS or LR. But if the patient is truly volume depleted, hypotonic, patient is hypotensive and has all the features of shock, yes, go with LR or NS. Because the reason they're hypernatremic is they're volume depleted. You fix the volume, you solve the problem. But if somebody is normotensive, not tachycardic, not hemoconcentrated, doesn't have any contraction alkalosis, does not have an AKI, no hypercalcemia, nothing in the labs to suggest volume depletion, go with D5W. So when it comes to fluid management, in patient with septic shock, you typically want to pick an isotonic fluid, such as normal saline or LR. The most isotonic is going to be LR. Why? Because that's how much you have of sodium, which is 134-ish. So normal sodium is about 135 to 145. So that makes LR the most isotonic fluid. Now if somebody's got lactic acidosis because they got septic shock, do you want to give them Ringer's lactate?
I think you still can.
Does Ringer's lactate have a lot of lactic acid in them or something? That is a complete misconception. Okay, you can give them lactate, you can give them Ringer's lactate perfectly fine. There's no such thing as you give Ringer's lactate, you're going to produce lactic acid. No, doesn't exist. You can give Ringer's lactate to your patient even if they got lactic acidosis. That's a complete misconception. Forget about that whole concept. So when it comes to fluid and you want to give somebody isotonic fluid, it typically is going to play around with LR or NS. What other types of fluid would you choose in your patient with septic shock? Once you've given the boluses and the patient is stable enough, you want to have maintenance fluids. It's typically 1 ml per kg to 1.5 ml per kg. So 1 to 1.5 ml per kg is what you're going to give. But again, remember, we always speak about volume status. You assess the patient's volume status and you determine every day how much volume you want to give them. Don't just blindly give them fluid and forget about it. So have to periodically assess. So say you give the patients fluid. You give the patients fluid and the patient is not being fluid responsive and the patient's got septic shock. What are you going to do next? Patient's blood pressure is dropping to 60 over 40. You've already given 3 liters normal saline bolus. Yes, you want to start the patient on pressors. The moment you've done your fluids and the patient's blood pressure is dropping even more, next very step is pressors, period. Nothing else. Jump to pressors. Now the question is, when it comes to pressors, what is the pressor you're always going to pick? You're always going to pick norepinephrine. That is going to be your number one pressor pretty much 99% of the time. I'll explain if you're thinking of something else in a second, but 99% of the time, always pick norepinephrine. Okay? Why? Norepinephrine is going to work on which receptors? It's going to work on your alpha-1 receptors in the blood vessel and cause it to squeeze and cause vasoconstriction and raise your blood pressure. It's going to stimulate beta-1 in your heart and it's going to cause increased inotropy and increased cardiac output, so basically raises blood pressure. That's a fantastic pressor to be used. Always want to pick norepinephrine as number one. Say you start the patient on norepinephrine and the patient's blood pressure goes up and you're like, alright, looks good, I think I'm happy. All of a sudden, blood pressure drops back down. MAP is less than 65 again. What are you going to do next? Yes, the second pressor to use on the context of septic shock is going to be vasopressin. What is your dose? Do you titrate it or not? You never. Phenylephrine. This is when you'll pick phenylephrine because phenylephrine is going to work on alpha-1 receptors and cause systemic vasoconstriction, raising your blood pressure. So it works beautifully. Whereas like the heart rate was okay or the patient was bradycardic, then you would pick epinephrine. So epinephrine, phenylephrine, you can pick whatever you want after the first two. It's just the gold standard, the first two, norepinephrine, vasopressin. After that, what you pick is fine. You can pick epinephrine, you can pick phenylephrine. What are the other pressors we know of that we can use? You can use dopamine, you can use dobutamine. What else can you use?